given, the dose per fraction, the volume of tissue irradiated, the technique of treatment, the size and extent of primary tumor. Definitely, this is very important. So hypopharyngeal cancers, they have highest risk of chronic dysphagia and stricture formation, followed by oropharyngeal, followed by laryngeal cancers. Acute toxicity, apart from just generalized hyperemia, erythema, ulceration, and edema of tissues, there is in the oral cavity, there is mucositis, there is voice change, there is xerostomia, soft tissue necrosis, and ORN mandible. Definitely, it occurs. There is a this also impacts the orodental hygiene. Now, the late effects, there is fibrosis and atrophy of muscles. There is loss of sensation and taste. There is decreased contractility of muscles and stricture formation. Changes in speech. So there is an entity known as radiation-induced dysphonia. Voice changes occur, which results from edema and dryness. Then so there is harsh, rough quality of voice. There is disturbed frequency of voice, and there is vocal fatigue. So patients are not able to speak for long periods because uh, they may also not be able to raise the pitch of their voice. So in terms of swallowing, again, because there is fibrosis and a lot of stricture formation, so there is reduced retraction of the base of tongue, incomplete closure of the epiglottis and larynx. There is decreased peristalsis as muscles are affected. There is delay in pharyngeal transit, poor coordination of swallowing muscles. There is poor synchronization of muscles and delayed opening of the upper esophageal sphincter. So many studies have been done where conventional radiation has been given, and on the other hand, intensity modulated radiation has been given. And especially for head and neck, certain structures have been demonstrated which post surgery, which post radiation, pathological changes are noted in these structures, and they contribute maximum to dysphagia post radiation. And these structures are known as organs at risk or dysphagia aspiration related structures. These include the superior constrictor, the middle constrictor, the inferior constrictor, the cricopharyngeal muscle, the esophageal inlet muscles, cervical esophagus, the base of tongue, supraglottic larynx, and the glottic larynx. So, what can we do to minimize dysphagia post radiation? One is the use of CT for target volume delineation. Also, we have to spare the organs at risk and the dysphagia associated structures. To do that, we are now usually using IMRT, which not only spares the organs at risk but also spares the salivary glands, which leads to lesser incidence of xerostomia. Now, the recent thing that has come up is that we are giving dysphagia optimized IMRT, which is basically aimed at sparing the swallowing structures or giving minimal radiation to these structures. So there is the DARS trial, which says that it was a phase 3 randomized multi-center trial where on one hand dysphagia optimized IMRT was given versus standard IMRT, and it was seen that dysphagia optimized IMRT is better, and the post radiation dysphagia in such cases was much less as compared to uh, uh, the conventional IMRT. Now, coming to the rehabilitation part, so voice, speech, and swallow rehabilitation. So, first is voice. So, vocal functioning assessment, it can be done by certain scales, which are the ones which are most commonly used are the voice related quality of life questionnaire, the voice symptom scale, the voice handicap index, then the perceptual voice evaluation, GRBAS is most commonly used. So then there is grade rough breathiness, asthenia and strained scale, or the Cape V. Then there is dysphonia severity index. Instrumental evaluation of voice is done by video stroboscopy. A diagnostic microlaryngoscopy may be required if a pathology is if a, if a polyp or a nodule is noted on the vocal cords, then a diagnostic microlaryngoscopy may also be done. Now, coming to rehabilitation of voice post laryngectomy. So, there are three modalities of rehabilitation of voice. One is esophageal speech, second is electrolarynx or the artificial larynx, and third is the surgical voice restoration. Esophageal speech, it requires air to be taken into the top of the esophagus either by injection or inhalation, and it is then forced out, causing the newly reconstructed pharynx, the pharyngoesophageal segment or the vibratory segment to vibrate in response to the flow of air and produce sound. As in case of a normal laryngeal voice production, the sound is amplified by resonating cavities above and modified into speech by articulators, which are the tongue, teeth, lips, and soft palate. The electrolarynx, it produces a sound that is transmitted into the resonating cavities either by direct pressure of the machine against the skin or of the upper neck or through a tube directly into the oral cavity. TEP or surgical voice restoration, it is basically creation of puncture at the time of the surgery or may be created at a second sitting, primary TEP or secondary TEP. Now, TEP is a fistula which is made through the posterior tracheal wall into the esophagus. It is a one-way valve. And once we insert a prosthesis, it is a one-way valve where only air can pass into the esophagus for voice production, but food and fluid are not aspirated. So, the most common cause of TEP failure post surgery is that we have a hypo or a hypertonic uh, pharyngoesophageal segment or the neopharynx. So, in case of a hypotonic neopharynx, uh, the swallow is functional, but the voice is of low quality. It is low, it is weak, it is whispery, it is wet. How do we manage it? We put digital pressure against the outside of the neck, artificially increasing the tone, and or a low opening pressure prosthesis may also be used. In case of a hypertonic neopharynx, increased pressure is required for swallowing. The voice is high pitched, it is effortful, and it is difficult to maintain. And how do we manage this? So during the time of surgery, we do a cricopharyngeal myotomy. Post surgery, or we can do a pharyngeal plexus neurectomy. And post surgery, if such a uh, problem arises where there is TEP failure because of hypertonicity, we can do botulinum toxin injections. Coming to speech, so speech is impacted by voice quality, resonance, and articulation. Assessment is done by understandability of the speech scale and the speech handicap index. So, speech and voice therapy for non-laryngeal cancers post chemoradiotherapy. It is aimed at three. One is maintaining vocal hygiene, giving adequate dietary advice, speech therapy by a specialist, and medical treatment. So, vocal hygiene is aimed at laryngeal hydration, gentle vocalization, minimizing vocal trauma or abuse or maladaptive hyperfunction, which occurs during the course of radiation. Voice therapy is aimed to overcome this maladaptive hyperfunction. How do we do that? We give certain vocal exercises with the aim of targeting and strengthening specific muscle groups and improving glottal closure and efficiency. We increase the awareness of and reduce excessive tension in the muscles around the larynx, neck, and shoulders. Then change in posture and improving breathing also impacts speech and can be improved upon. Then there is laryngeal massage and psychological counseling, which is given to the patient. Medical management is basically we treat the underlying acid reflux, treatment of any URTI, LRTI, or any allergies. we have to treat radiation induced hyposalivation. So we use cialogogues or oral mucosal lubricant or salivary substitutes. Intraoral electrostimulation of salivary glands may also be done. Then mucositis needs to be taken care of. So good oral hygiene maintenance and regular gargles is helpful. Also pain management, because the ulcers post radiation are very painful. Now coming to swallow. So clinical assessment of swallowing, history taking is very important. So signs and symptoms, coughing during or after eating and drinking is characteristic that the patient might be aspirating. Then there might be hoarseness, choking. Then so a complete head and neck examination is warranted. Certain questionnaire based assessment methods for dysphagia are there. Most commonly used is the MD Anderson Dysphagia Inventory. Others are SWAL QOL, SWAL Care, then Sydney Swallow Questionnaire, University of Washington Quality of Life. Then there are certain observer related questionnaires, which is the performance status for head and neck. Now, certain perceptual test, which is the blue dye test or the water swallow test. So the blue dye test is usually done in tracheostomized patients to see whether a patient is aspirating or not. So we give dye mixed with water. We give it to a patient who's tracheostomized, and post swallowing this dye, this colored water, if the patient coughs or if there is spillage from the tracheostomy, or on suctioning, if we find the dye from the tracheostomy, then that means that there is aspiration. So we have to check both the immediate and the delayed phase for aspiration. Next is the water swallow test. We give a defined volume of water, 100 ml, and look for any abnormal voluntary cough, post swallow cough, throat clear, or we check the voice after the water swallow test. Next are the instrumental based measures. So there is fiber optic endoscopic evaluation of swallowing. Then there is flexible endoscopic evaluation, swallowing and sensory testing. There is modified barium swallow. So FEAS is an endoscopic examination of the upper aerodigestive tract. It is useful in identifying aspirations and silent aspirations also. The advantage is it can be easily done. It's a bedside test. And the only disadvantage is that the oral phase of swallowing cannot be assessed with this. So another advantage is that endolaryngal sensation can also be checked at the same time. So what is it that we see when we do a laryngoscopic examination? We go as per the penetration aspiration scale, where penetration is that the bolus material, it comes in contact with the true vocal cords without entering the larynx, and a frank aspiration is that the materials enter uh, the lower airways. This may or may not be cuffed out depending on the grading. Now, radiological investigations include a contrast swallow and a video fluoroscopy. The contrast swallow, the barium swallow, it includes both static and dynamic assessment. A patient is given a cup of liquid barium to swallow, and bolus is followed fluoroscopically to the stomach. The video fluoroscopy is actually the gold standard for evaluating the swallowing mechanism. All three phases of swallowing can be assessed, and also maneuvers can be given to the patient, and the effect of the maneuver can be assessed using video fluoroscopy. Now coming to management. So there is prehabilitation, then there is management immediate post surgery, and management post radiation and chemo, and then long-term management of dysphagia. So there is this concept of prehabilitation, where rehabilitation starts prior to surgery or radiation. That is, before commencing the definitive treatment, we rehabilitate the patient. So what all do we do? There is a baseline assessment of speech and swallowing. Then there is a dental examination. The prophylactic swallow exercises, they can be offered to the patient, and this also improves compliance in the post-operative or post-treatment period. Then adherence promoting interventions like behavioral change technique, home-based mobile applications, and virtual coaching can be done. And baseline nutritional assessment needs to be done for these patients, uh, based on whether how a patient is doing, whether he or she has a safe swallow or not. Again, rehabilitation needs to be planned. So before starting treatment, a peg tube or a RT insertion may be considered in some cases, not all. So immediately post surgery, there is placement during the intraoperatively. We placed a Riles tube to commence early feeding. Swallowing exercises are usually started on post-op day 4, and assessment, a swallowing assessment uh, uh, by an expert is done on post-op day 5. For tongue resections, it is usually post-op day 5 and 6 that is considered, as we give adequate time for healing. Once the assessment is cleared, so this assessment can be done by the blue dye test. Uh, Once there is no aspiration, then patients are started on oral sips of water. Once the patient has taken adequately, that is 1 liter oral intake is there, then we can proceed for removal of the RT. We can change the consistency of the feed by giving full liquid or blended diet for the patient. Once the patient is taking normally, then soft diet can be given, and gradually the patient progresses to normal diet. Once we have removed the RT, there is no aspiration, patient is taking liquid or blended diet comfortably, process of decannulation may also be started. Now, long-term dysphagia management, it comprises of compensation, rehabilitation, and adjunct modalities. So management is defect-based. It requires a combination of compensatory and rehabilitative strategies. Compensatory strategies, they are short-term, temporary measures. They do not aim to change the swallowing mechanism. They usually include postural modifications. Rehabilitative strategies, on the other hand, are based on the principle of use it or lose it. So they target a neuroplasticity. They are more long term. They impact the swallowing physiology. And these usually include exercises where we do resistance training of the muscles and muscle strengthening exercises. Now, the exercises, these may be direct. Direct exercises are done without, with the involvement of the food, and indirect, where the exercises are done without the involvement of the food. This is basically in patients who do not have a safe swallow, or who do not have a safe swallow. Now, coming to oral stage disorder rehabilitation, first is the lip. So the labial range of motion exercises, we ask the patient to tightly stretch and purse the lips in contrasting E and U position. We ask the patient to press the lips together, open the mouth as wide as possible and hold for 5 seconds, and smile as wide as possible. Multiple cycles of these exercises need to be done, and not just one. So this improves labial closure and strength. Now, lip strengthening exercises are the resistance exercises. So this improves lip strength and range of motion. So we hold a tongue depressor between the lips, and the clinician tugs to remove it, or apply some pressure to remove the tongue depressor. And we check how much strength the muscles have on the lips. Then straw drinking and button and thread exercise, where a button is placed inside the oral cavity, and the patient himself or herself can pull it, or this can be done by a clinician. Now, coming to buccal mucosa, so tilting the head to the stronger side, head tilt to the stronger side is done so that gravity drains the bolus along the strong side and avoids the weaker side. This usually protects the airway, but it may be slightly difficult for patients with tracheostomy to perform this. For tongue, so we have range of motion exercises which improve the tongue flexibility, strengthen the tongue muscles, and improve the range of motion. These include the tongue tip elevation, the tongue base retraction, the tongue propulsion or retraction, lateralization movements to left and right of the mouth. So, if there is a reduced vertical tongue movement, so tongue range of motion exercises are considered maxillary reshaping prosthesis, head back posture, and head tilt to the stronger side. If there is a reduced anterior to posterior tongue movements, then head back postures, multiple swallows, we alternate liquids and solids. Then tongue range of motion exercises, bolus manipulation exercises, and again prosthesis may be used. And if there is a reduced tongue strength, then effortful swallow and tongue strengthening exercises. So reduction in the tongue elevation, we ask the patient to tilt the head back up. So this is also known as the chin up posture, where by keeping the head back, we use gravity to clear the bolus from the oral cavity in those who have a problem with oral transit. This cannot be used in patients who have poor lingual control have impaired airway closure, and this might be difficult for patients with tracheostomy. Now, tongue range of motion exercises, they improve the tongue flexibility, strength, and range of motion. So there is tongue tip elevation, tongue base retraction, tongue protrusion, retraction, and lateralization movements to the left and the right of the mouth. Then tongue strengthening exercises. So we provide some kind of resistance. This can be done with the help of a tongue depressor or a spoon, and we ask the patient to push the tongue against the resistance. We can also use an IOPI, which is a pressure transducer. This gives a visual feedback on how much tongue pressure is generated. Now coming to jaw range of motion exercises for reduced mouth opening or trismus rehabilitation. So, unassisted jaw opening and closing is the patient is asked to do unassisted jaw opening and closing. Then mechanically, we can assist jaw opening with stacked tongue depressors or ice cream sticks, which is most commonly done in OPD. Then we may also use Therabite for trismus rehabilitation. Now, pharyngeal phase, if there is a delayed pharyngeal swallow, then we ask the patient to perform a chin down or a chin tuck chin tuck maneuver where airway is protected and the entrance of the airway is basically narrowed and the valvula is widened. Other exercises are super supraglottic swallow and thermal or tactile stimulation may be done. Now, in case of reduced tongue-based retraction, chin down posture, effortful swallow, supraglottic swallow, Masako maneuver, these may be done. And certain range of motion exercises like retraction of the tongue as far as possible, yawn, gargle, effortful swallow may be done. So how do we perform an effortful swallow? This is basically to improve the posterior movement of the tongue base and to increase oropharyngeal pressure. So,
swallowing exercise be
so we start with the tongue at rest. We press the tongue against the roof and we swallow as hard as we can. We first keep the water in the mouth and we swallow as hard as we can. So this increases the posterior tongue base movement. Now, next is the super supraglottic swallow. So the purpose is to reduce closure of the laryngeal vestibule or airway entrance. How do we perform?
Hi, superglottic swallow. I'm going to use some water today. I'm going to take a sip and hold it in my mouth. Take a breath in through my nose, holding my breath. I'm going to swallow while holding my breath. Remember to cough right after. Again, from the side, you can swallow in.
So the rationale is that effortful breathing, breath holding tilts the arytenoids forward, closing the airway entrance before and during the swallow, and this helps to prevent aspiration. Next is the Mendelssohn maneuver. The purpose is to improve the range of the laryngeal movement. It improves the opening time of the cricopharyngeus. Laryngeal movement upward and forward opens the upper esophageal sphincter and prolongs the elevation of the hyoid or the larynx movement and sphincter opening time. Coming to the Masako maneuver or the tongue hold maneuver. So we protrude the tongue maximally, then we hold it in between the central incisors and this increases the anterior bulging of the posterior pharyngeal wall and increases the pressure, and we try to swallow the saliva uh, in the mouth. And post the swallow, we just relax and we have to repeat this 3 to 4 times. Now coming to the larynx, so if there is a reduced laryngeal vestibular closure, so we have the chin down posture, the supraglottic swallow, effortful swallow, reduced laryngeal elevation, we have the Mendelssohn, the chin down, laryngeal range of motion exercises, the shaker exercise. If there is reduced glottic closure, then we have the head rotation to the weaker side, supraglottic, and we may use thickened liquids. So this is describing the shaker exercises for hyolaryngeal range of motion. So to increase the hyoid motion, uh, what we first ask the patient to lie down flat, and then we ask the patient to keep the shoulders flat against the bed and lift up the head and bring the chin down close to the chest. We ask the patient to keep the head lifted for 60 seconds and then lower the head and rest for 60 seconds. The second part is that we ask the patient to again keep the shoulders flat against the bed, lift the head, bring the chin down to your chest, and immediately lower the head. So this sequence needs to be repeated at least 5 6 times. Now, compared to coming to impaired cricopharyngeal opening, so shaker exercise and effortful swallow is useful. Adjunct strategies for dysphagia management include dietary modification and sensory enhancement. So, texture modification or bolus volume modification may be done. Then, for sensory enhancement, thermal tactile stimulation may be done, or change in method of presentation, as in a spoon, straw, cup may be used, whichever is suitable for the patient. Carbonation of liquids may be used, and taste modification. Use of sour boluses is helpful. Coming to prosthetic rehabilitation, this is important where we have palatal defects, and so a palatal drop or lowering prosthesis may be used. Newer modalities include EMG biofeedback and neuromuscular electrical stimulation. So with that, I come to the end of the presentation.
Excellent. Sangini ji, you have done it very well and covered almost all things. And I think everyone should understand that we should, as a surgeon, do pre-operative counseling and tell the patients beforehand what are likely consequences of the surgery or radiation or whatever treatment you are planning. And I hope that all the hospitals, they have speech swallowing therapist. Most of the good cancer centers do have. And the third aspect which I wanted to highlight was what is the role of surgery in rehabilitation, speech swallowing rehabilitation? That is also an important part of speech swallowing therapy in the form of surgery.
Yes, sir.
And any questions? Chat box is empty. Okay. So lastly, I will just say 27th July happens to be World Head and Neck Cancer Day. So all of you must celebrate it and try to create awareness in whatever way about head and neck cancers.
Yes, sir.
You are doing it in your hospital?
Yes, sir.
Good, good, good. हाँ जी, Mr. युवराज जी. Mr. Yuvraj?
Yes, sir.